So our next speaker is Dr. Emma Hainsworth, nurse researcher at Applied Healthcare Research Group from the Royal Marsden. And she's going to continue on the subject of healthcare inequalities, those experienced by people living with HIV having cancer treatments.
Thanks ever so much for inviting me to speak today. My name's Emma Hainsworth. I'm a nurse researcher at the Marsden, and I'm going to be talking about a group of people who are living with HIV and treated for cancer. And they're a group who can face multiple health problems, and they can have combined and intersecting challenges which can have a negative impact on their outcomes. So, in terms of my own background, I'm a nurse who's worked in both areas, and I worked in HIV care in the 1990s at a time when there wasn't any effective treatment available, and that left a really great impression on me. Some of these photographs that you can see are from that time by Gideon Mendel, and I maintained a really passionate interest in exploring the experience of people with HIV and how they came out of that time and then came into contact with different services, including cancer services. So since that time, we've had an incredible amount of progress in HIV treatment, and it's been good news. So now we have effective HIV treatment, which is really easy to take. And we have this U equals U message, which is so important. So if people are taking effective treatment for a period of months and their HIV viral load is undetectable, then it's just not possible for them to transmit the virus. So they can't pass it on. And this is great news in terms of transmission, but also for removing some of the fear around the virus. So as people are getting older, they're increasingly likely to get age-related cancers, common cancers like prostate and breast cancer. But they are at increased risk of other cancers too, particularly those that have a viral cause. So anal cancer, cervical cancer, and some head and necks are linked to HPV. They can be at increased risk for liver cancer due to hepatitis and Hodgkin's lymphoma due to Epstein-Barr virus. And this group also has been shown to have higher rates of modifiable cancer risk due to smoking and alcohol intake. And so that it's increasingly likely that we're going to encounter people with HIV in our services. And we need to be aware that they face intersecting challenges. And I think Stuart alluded to stigma earlier, and certainly people with HIV face HIV-related stigma. And that can be actual discrimination, or it can be what I would call self-stigma or anticipated stigma, where they've internalized those negative attitudes and they expect to be treated less favourably. And that can be just as harmful for their experiences of healthcare and actually seeking healthcare. When they are treated for cancer, they're receiving care from different specialities, and that can be difficult to negotiate. They're going through all the usual toxicities of cancer treatment, and they may well be part of the LGBTQ+ community, or they could be a migrant or from a racially minoritized group. And as people with HIV get older, they have an increased risk of frailty and comorbidity. So one person living with HIV and treated for cancer might not have all of these, but they may have a combination of these factors which make them more vulnerable. So I've done some research on their experiences. And in 2019, I finished a PhD, which was all about exploring their experiences of being treated for cancer. And what I found was that they experienced a convergence of pressures which were both visible and invisible. So in cancer, it was very visible. They could talk about their diagnosis and get support. It was socially acceptable. But people were still keeping their HIV status a secret. And they had that burden of managing information. They may come to appointments, with someone who was unaware of their HIV status and then be quite worried that it was going to be revealed in the consultation. So that was obviously very burdensome for them. They reported feeling a little bit out of place in cancer services sometimes. They definitely demonstrated this self-stigma, so they anticipated negative treatment, whether or not they received it. And oftentimes they didn't, but they anticipated it. And they felt responsible for their HIV care and treatment, and described like having to check drug interactions themselves or carry that responsibility. So the implications for this is that sometimes our standardised pathways don't recognise the invisible pressures that people face. We may need to know a little bit more about HIV and its treatment, and we should acknowledge the impact of HIV stigma on people. So as a researcher, a methodology that's really good for developing person-centred care and exploring experiences is something called co-production, and that involves working alongside the people affected and coming up with solutions or tools or resources together. And in that way, you can tailor what you develop very much to the needs of the person. And a project that I was involved with, which used co-production, was the development of 3 videos which we housed on the National HIV Nurses Association website. And they were first-person accounts of people living with HIV, just trying to kind of convey the complexity of their experience. And I'm going to show you a video of one of these people, Gordon. He's a gentleman who was... we did this filming during the pandemic, so there was clearly that particular stressful situation. He was being treated with chemotherapy for myeloma at the time, and he describes other issues that he was facing that perhaps weren't visible to the staff who were looking after him.
I think what's become too much is how vulnerable I've started to feel, and certainly how isolated I've started to feel. And I'm not sure that the clinicians that I'm seeing, who themselves are living in a pandemic and must themselves be under lots of pressure, I'm not sure that they're able to see all the stuff that might be going on under the surface for me. So right now I feel as though I'm on so many different drugs that I don't really know where to turn. And so when I'm seeing one doctor, I'm saying, well, could these drugs be affected, the drugs that you're giving me, be affected or affect the other drugs? And they're like, no. Or I don't know, but they're not looking into what's happening. Which leaves me feeling that my care is being compartmentalised into sort of different areas. So I've developed a urological problem. I've developed bladder retention. So while I'm going through chemotherapy, I'm going through treatment. I take daily treatment for ADHD, and we don't know exactly what the interactions between those drugs, it's an amphetamine-based drug, will be with the other drugs. I've developed urinary retention or bladder retention. I'm doing chemotherapy, and I'm on HIV medication. And it doesn't feel at any time that any of the clinicians are looking at me holistically, not even the CNS. And that's something that looking at me as a whole person feels really important to me. And it feels as though the whole person is being ignored. And this kind of brings on a whole lot of pressures on my life, on me in my life, to coordinate a whole lot of communication. And while I think that the CNS can do that for me, is the link between my oncologist and myself, there's no one really coordinating all the rest. And sometimes I just feel so unwell that I'm unable to advocate for myself, and that I need people to think much more holistically about me and my care, and look at the various factors, environmental, social, financial, to be able to give me the best care possible. Because I'm not just living with cancer and HIV. There are many, many things happening in my life on top of those.
So that was quite a powerful account, and it's good to hear from the people themselves so that you can appreciate what they're going through, because I think you could see Gordon and perhaps not appreciate that there was all that going on under the surface. So my last slide, following on from making the videos, I'm carrying on doing some work with HIV and cancer, and I've applied for funding for a project to develop person-centred care for people with HIV and anal cancer, and I'm hoping that that project will start in September. So thank you for listening. If you have any questions and you'd like to discuss things further, please, I'll be at the World Cafe tables and we can talk about that then. Thank you very much.
Thank you very much, Emma. Again, that was another really inspiring and interesting talk. The video with Gordon was the complexity of his care and the multiple. You could just see it happening, going into one doctor's appointment and being given a plethora of drugs for like chemotherapy or SATs, and then going to a different doctor. And it's just having that responsibility while you're having treatment and feeling unwell. And I think sort of holistic care is the holy grail for all of us, and it's what we should be aiming for. And you feel like you've maybe got it, and you hear that story and realise we haven't moved on as far as we think we have with the whole holistic care. So thank you for bringing that up.